This lecture is going to examine some of the treatment options that exist for ADHD, or attention deficit hyperactivity disorder. Learning objectives are pretty straightforward, essentially list and describe the mechanism of action and the side effects of the drugs that are used to treat ADHD. In terms of initiating treatment for specifically children with ADHD, there's several criteria that would need to be kind of investigated before one makes the proper decision for which drugs are going to be used to treat this condition. Obviously, we have to make sure the diagnosis is correct. And typically, we don't start really treating children until after 6 years of age. And of course, the parents must consent to a pharmacologic approach to management. And then other criteria are listed here: that the child has normal heart rate and normal blood pressures, that the child has been seizure-free, and then doesn't have any other underlying pathologies or syndromes, and so they shouldn't have a Tourette's syndrome. Some of these treatments may actually worsen Tourette's in these patients. That these children may not have developmental delays or significant anxiety, because again, these treatments may actually worsen or contribute to their anxiety. Of course, the choice of pharmacotherapy also, several factors can play into this. How long you want the drug to work. Some parents just prefer their kids to be on a Monday through Friday regimen. Some parents insist that the children also take these medications over the weekend. Whether or not the child can physically swallow pills or capsules, the time of day when many of the target symptoms occur most. Some students and parents don't like to be pulled out of school, and so they don't want their fellow students and the administration to know that they're on these medications, of course. And so, and we'll talk about the pharmacokinetics of some of these very briefly. Some of these are short-acting, some of these are longer-acting, of course. Coexisting of other conditions, of course, is something to always kind of keep in the back of your mind, as well as the adverse or side effect profile of some of these drugs. And of course, the expense also plays a major role into choosing which of these drugs is the most appropriate pharmacotherapy. Now, in terms of the drugs that exist for ADHD, there aren't really that many. And what I've done is, in this lecture, I have referred to the brand names. Not that I necessarily need you or want you to know them, but there's just so much media attention in terms of the brand names. I just figured it'd be easy for you to kind of put these drugs into some sort of phenotype, or just have a basic understanding of how these drugs are administered. And so the first one we'll talk about is methylphenidate. Methylphenidate is the generic name for Ritalin, and this is a stimulant. It primarily affects both dopamine and norepinephrine reuptake pumps, and so it's an inhibitor of those pumps. And if you inhibit the reuptake of these drugs, or the reuptake of these catecholamines, essentially you allow more neurotransmitter to exist for longer periods of time in the synapse. The side effects basically mimic some pathomimetic signs. They're relatively quick adopting. They occur quite readily because, of course, these are catecholamines. You can see suicidal ideation. These drugs come with a very stern black box warning. If the patient, the child, has any suicidal ideation, that can be grounds for discontinuation of therapy. These drugs are stimulants, of course. They produce a loss of appetite. They can produce GI upset, cardiovascular problems, insomnia in patients with underlying psychosis. They can produce or exacerbate the onset of tics. And so the kinetics of these drugs varies from the short-acting 3 to 6 hour formulations to the longer-acting 12-hour formulations. And this is kind of a typical dose-response curve in terms of what you would see from most of these type of drugs that are in the methylphenidate class. The patient is slightly fatigued at the onset of therapy. They become more alert, and then at some point they can also get stressed a little bit. And so this is pretty common, these peaks and troughs during therapy for these patients. And so what we do is we try to minimize that. And you can play around with some of the kinetic profiles of the various formulations so that these peaks and troughs don't happen when they're in school or when they're doing specific activities. And so you can kind of play around with the time of day as to when these drugs are given. Another indirect acting agonist is dextroamphetamine, and so it is amphetamine. Of course, it's a stimulant. This is under the brand name Adderall. From a mechanistic standpoint, it's going to affect the reuptake of catecholamines, such as dopamine and norepinephrine, but also indolamines, such as serotonin. It also increases the release of these monoamines into the synapse. The side effects are also similar to the other sympathomimetics, and so these are basically drugs that look like agonists or drugs that behave like indirect agonists of norepinephrine or dopamine. You can see the loss of appetite, insomnia, GI irritability, emotional liability, the onset of tics. All these side effects are pretty common to these drugs because they obviously occur through various mechanisms that are common across the board. And of course, you can see a kinetic profile where we can differentiate some of these different formulations based on the duration of activity from the short-acting to the long-acting. And so in terms of choosing between the stimulants that exist, the primary consideration is really the kinetics that basically contributes to the duration of action. The short-acting formulations are listed here, and again, I put the brand name just for comparison's sake, so that you guys have some reference to things that are more clinically relevant. Methylphenidate or Ritalin has essentially the shortest duration of activity. And then we can kind of go into the intermediate to long-acting, where there's a methylphenidate ER, which stands for extended release, that goes up to 12 hours. There's a dexamethylphenidate extended release, which can go up to 12 hours. And then there's an amphetamine dextroamphetamine combination therapy that also is extended release, and that'll work up to 16 hours. And so for the older students, middle school, high school students that have kind of long days, these might be a valuable option. Another indirect acting agonist is atomoxetine. This is a slightly different class. This is under the brand name Strattera. These are good alternatives to stimulants, but however they are less effective because they're less potent, but also well tolerated. Atomoxetine specifically blocks the reuptake of norepinephrine. It does have a pharmacodynamic interaction because this is metabolized by certain CYP-P450 enzymes. Major side effects include weight loss and abdominal pain. The sympathomimetic signs are relatively rare. The suicidal ideation still kind of occurs with this and other drugs in this class. And of course, you can see liver toxicity coming from metabolic byproducts. Contraindications basically to atomoxetine are patients that are on monoamine oxidase inhibitors for depression or other conditions. And they've got a kind of an intermediate duration of activity from about 10 to 12 hours. And so these are typically dosed twice daily. The next group of drugs are the alpha-2 receptor agonists. And so remember that the alpha-2 goes into a negative feedback loop. When alpha-2 is stimulated, which you see here, is a reduction in the release of norepinephrine. Okay, I just want to have you guys remember that key concept. Even though this is a alpha-2 agonist, the physiologic outcome is less norepinephrine. Okay, and so you see a reduction or an inhibition in the release of norepinephrine from the neuron. And so the alpha-2 agonists, essentially clonidine is the prototype here. There's another drug on the next slide. These are alternative agents when no response to the stimulants or atomoxetine is observed. Okay, so again, these are alpha-2 specific receptor agonists, and so there's a profound reduction in norepinephrine release because we're kind of perturbing that negative feedback loop. This will also result in a lowering of heart rate and cardiac output. And the target here is really the medulla of the brain. In terms of indications, we're looking at several: hypertension, withdrawal from abused drugs. We had talked about the effects of clonidine, specifically in Tourette's patients, to treat the tics, as well as ADHD. Side effects are typical: dry mouth and sedation, and severe hypertension in massive overdoses. The contraindications to this drug are patients with a history of depression, and there are several known drug-drug interactions with tricyclic antidepressants. Guanfacine is another drug, an alpha-2 agonist that works similarly. It does cause a profound reduction in norepinephrine from the release in the CNS, and that negative feedback release, very similar to clonidine. Indications are listed here, and the duration of action is similar as well. Bupropion is the last drug in this category, and we're not quite convinced that it's as effective for ADHD, but it has other central disease targeting effects. It's been used for depression, bipolar disease, smoking cessation, etc. And this affects, of course, dopamine and norepinephrine. It's really been shown to be efficacious in reducing the hyperactivity and as well as the aggressive behaviors that sometimes come along with them. And of course, the main contraindication here is patients with a history of seizures. So this is the kind of the main drugs for ADHD. If you have any questions, please email me, and thank you.